Hi, my name is Rahul Banerjee. I'm an assistant professor of medicine at the Fred Hutchinson Cancer Center in Seattle, Washington. I'm here at the 2025 IMS meeting in Toronto. It's been a fantastic meeting so far. A big topic at all the meetings, this meeting in particular, is the idea of functional high-risk multiple myeloma. All of us know about high-risk myeloma, right? The topic comes up, one of the first things that patients and doctors talk about when they're first diagnosed. And that's important, but it's also problematic, because the only time we really talk about it is at the very beginning. Historically, and even now, high risk is often defined by features at diagnosis in terms of what the cytogenetics show, what the FISH testing shows. Some of you may be familiar with. There's new high risk criteria that came out this year that's also looking at genetic testing for a gene called P53. Now there's also a way where if someone's beta-2 microglobulin, which is a protein, is high at diagnosis, they're considered high risk, so forth, but it's all at diagnosis. And we know that about 20 to 30% of patients, even despite being standard risk at diagnosis, still have relapses earlier than we expect. And it's really frustrating. And honestly, those are some of the scariest scenarios for both patients and doctors, where the patient went through all this rigmarole, went to transplant, and expecting 4 to 5 years of remission, and 8 months after transplant, the myeloma's back. We call that functional high-risk myeloma. We've never really known what exactly it is. Is it a combination of the myeloma cells being aggressive? Is it a function of the immune cells not doing their job afterwards? We don't really know. Tomorrow I'll be presenting an oral abstract looking at a third criteria, possibly, that the induction therapy that people received. To put it another way, I have had patients who have early relapses earlier than expected, and sometimes we try to justify it, saying that, well, the patient, for whatever reason, didn't receive the optimal therapy that we would now recommend the patient diagnosed today. It may be that they were diagnosed before, for example, DARA-VRD became common. It may be because they couldn't get DARA-VRD or something similar, or quadruple it because of kidney issues, etc. And we kind of justify it to ourselves, being, oh, well, the reason the relapse happened earlier is because your frontline therapy wasn't optimal, and therefore this early relapse is not a problem. We don't need to treat it more aggressively. We don't need to talk about CAR-T therapy, etc. Long story short, a multi-center group of us, we looked at data from published CIBMTR studies. CIBMTR is a large registry looking at patients who have undergone transplant anywhere in America, and looked at all the patients in all those studies who had functional high-risk disease biology, so relapse within 1 year of transplant, and we looked at whether the induction therapy mattered. If someone got a quad or a triplet, did they get lenalidomide versus not, etc., did it make a difference in terms of how they did afterwards? Long story short, it didn't. And so functional high-risk disease biology is functional high-risk disease biology. What that means for patients listening to this is that, if you're in that unfortunate position where the myeloma came back sooner than you expected, this is not the time to point back and say that, well, maybe it was because of something from induction. I think when you see this happen, it means that the disease is doing something that we don't like. And I think the best tool that we've seen for these patients actually is CAR-T. And one of the other sessions here, polled the audience, and overwhelmingly doctors preferred CAR-T therapy at first relapse for patients who've had these early relapses, functional high-risk disease biology. And work from Dr. Costa and colleagues from a trial called CARTITUDE-4 did show that. For patients who have early relapse, earlier than expected, if they can get CAR-T therapy, those patients did much better than patients who got traditional second-line treatments. Whether every patient in all of America, all of the world, needs CAR-T at first relapse, I don't know. Probably the answer is no. To be honest, truly in my heart, I don't advocate for CAR-T for everyone right away. Some patients don't want CAR-T. Some patients can't get CAR-T because of medical comorbidities, other issues. Some patients, clinically, their disease is such that CAR-T is not practical for them. But I think we're seeing more and more here that functional high-risk disease is a function of the disease of the myeloma. And so when it happens, don't point fingers at the treatment that they got before. Just say, look, it's happened. Time to move on to our newest, brightest tools. And for most patients, that's CAR-T.